we have another exciting speaker who we've met and talk. Dr. Kelly Casperson will now speak to us about my best sexual health advice. And for those who are tuning in right now, Dr. Casperson is a board-certified urologic surgeon and founder of the Casperson Clinic, a modern practice focused on hormones and sexual medicine. She's the host of the top-ranking podcast, You Are Not Broken, and a nationally recognized speaker and educator. Her work focuses on evidence-based education in sexual health, intimacy, and midlife wellness. Welcome back, Dr. Casperson.
Hello, sex doctors. Woohoo! I never want to hear anybody say, I'm just a primary care doctor. I never want to hear anybody say, I'm just a nurse practitioner. Do not diminish the effect that you have on people. We have 1,750 people at this conference this week. You will all go out and help people with their hormones and their sexual health and their partners, and then the sisters, and then the daughters. And this math adds up fast. This is how we change the world. This is how we say, status quo is not good enough, we want better, and we're gonna do it, not because we're just anything, but because we care enough about all humans to help them live their best lives. So thank you to all of you guys for being here. I don't know if it's the right term, but it's Freaky Friday this afternoon because we're all doing sex med. So thank you for making it last to Freaky Friday. My best sex health advice, this is me getting to rant for 45 minutes straight, so I appreciate the platform for doing so. I'm wearing a very nice dress, which does not have pockets. So, this is a tube of testosterone gel. Because of the Olympic doping scandals of the 1980s, the United States Congress, against the advice from the FDA and the DEA, because they weren't involved, the United States Congress voted the Anti-Doping Act of 1991. One hormone that our body naturally makes, all bodies naturally make in adrenal glands, testicles, ovaries, and peripheral conversion. One hormone our body naturally makes got put on the list. It remains on that list today. I'm hopeful by the end of 2026, we're going to deregulate testosterone, something your body naturally makes and most people do not abuse to become Olympic gold medalists in pole jumping. That's what I tell my patients. I'm like, I will not make you an Olympic gold medalist in pole jumping. I will not do it. So one packet, just so everybody can see, I used to pass this around at my talks and it would never come back to me. So now people are like, can I see it? I'm like, you can see, but you can't touch. This is mine. This is 1 day for a male. Women have to use it off-label. I call it bootstrapping. Women have to bootstrap. Your ovaries make this. You have to make this last about 7 to 10 days. I like things with caps because this is alcohol-based and it can evaporate. That's why the ketchup packets we don't like. I'm wearing Spanx. I will not be demonstrating this on my calf. So I'm going to put it on my forearms, but site of application can have hair growth. So that's why we don't tend to do it a lot on the forearms. I'm not going to die. So kick in 3 to 4 hours. If I want to check out my C max concentration, I would get a lab drawn in about 3 hours. Dinner tonight with reservations with my friends is about that time. I'm going to have a great time. So this is what I tell my female patients about testosterone. There's 2 types of women who take female testosterone. The first, oh my gosh, this is so great. This is so amazing. It worked right away. 2 weeks, my brain is back, my muscles are back, my sex life is back. I've got some great ideas. I don't hit a wall at 3 p.m. My sleep is great. And the other group of women hate those women. And I always say that to my patients because they're expecting this to be a light switch immediately, and that's how it works for some people. But it doesn't work that way for everybody. And if I tell them a funny story up front, when they come back and they're like, it's not working yet, blah, 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 blah. I'm like, remember, there's 2 types of women with testosterone. Light switch women and the women who hate those women. Let's give it some time. because we want things really, really fast. And I say with hormones, start slow, start low, always go up. The body hates drastic change. Hair hates drastic change. Whether it's rapid weight loss, chemotherapy, thyroid issues, hair, pregnancy, postpartum, hair hates drastic change. And talk about something that's not studied, hair loss in midlife. 50% of women, hair loss in midlife. So the data says female dose testosterone does not increase hair loss compared to placebo. You give people placebo, they complain of hair loss, right? So the studies, testosterone's not worse than placebo. I believe those studies. And then we have women who say, I lost hair with testosterone. I believe those people. So who do we believe? We believe everybody. But if you are at sea level and you go to Mount Everest base camp in one day, it feels really icky. You can have big side effects from it. Sometimes it feels amazing, but it can also feel icky. Start low, go slow, much less side effects. Body hates being shocked. I would say, I love the body. Let's be kind to the body. Go slow. The other thing I want to talk about before I get into my regularly programmed slides is in midlife, you might see this woman. My husband is taking forever. Just sitting there, and I'm like, they say it a little bit nicer than this. He's taking forever. What they mean is when he puts his penis in her vagina, it's taking him a long time to climax an orgasm. This is no good if you were never aroused in the first place, if you have GSM, if you haven't figured out lube. It hurts. She's going to want sex less. There's a big industry marketing to women that they need to be tighter. Do I need to be tighter? Am I too loose? Is he noticing? Blah, 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 blah. Erectile dysfunction. 40% of men will start having erectile dysfunction at age 40. 40 by 40, 50 by 50, 60 by 60, 70 by 70, very easy to remember. Erectile dysfunction. Stop blaming the woman for his erectile dysfunction associated with aging. So I just see that a lot and nobody talks about it. So to me, it's always like, who's taking care of him? What's his testosterone level? Has he seen anybody to take care of him? Has he been worked up for heart disease? Right? So often in relationships, there's two people, sometimes there's more than two people. Who's taking care of your partner? Don't always blame her for something that's changing in his body. So those are like pearls of boots on the ground work that I wanted, and I hadn't put those in my slide. So disclosures, I run a podcast, I have sex, and I consult with some patients. Sex makes people feel very, very awkward. If in any of our talks, you felt something. That's called a feeling. Surgeons have one feeling. It's called tight. But feelings come up with sex. That doesn't mean this is a bad topic. It means your body is telling you something, and maybe we can learn from it, journal, all the things. We all come here, again, with our histories, with our traumas, with our experiences, and sex is very, very awkward for a lot of people. So I want to acknowledge everybody in the room and to say, I see you, I hear you, trust your body, and sex can be awesome, and I will try to teach you as much as I can. Also, heteronormativity exists everywhere, including in sex. We have much more data in the heterosexual world than other options, which are just as beautiful, just much understudied. So World Health Organization actually has a comment. Sexual health is a state of physical, mental, and social well-being in relations to your sexuality. Sexual health is health. We are all here because of it. It's unbelievable. I'm still waiting for like the test tube. I'm like, do we call them test tube babies anymore? I don't know. That was like a 90s thing. I'm like, do we call them the unhoused? Like, most people are here because of sex, right? And so it's an amazing thing to be like, this is universal healthcare. It's very, very cool. But sex is heavily laden with abuse, with trauma. It's just, we cannot separate it at this point, and it must be acknowledged. So a lot of caretakers say, it's a can of worms, I don't have time. So I'm going to try, if I can, to say, how can we do this in limited resources? We might not have sex therapists, we might not have insurance approval, we might not have every single 25-year randomized placebo-controlled trial to back us up, but how do we do this to help care for humans? I had a different word besides incorrect things, and Dr. Deborah made me change it because it's Harvard. Just use Crisco. Crisco is an ultra-processed food. We don't even bake with it. Please don't put it on your genitals. get a new boyfriend, just do it anyway. These are all real things that people are told because of lack of sex education on the hands of the provider at limited time, limited resource. But at the end of the day, withhold the urge to say anything trite or dismissive. And again, going back to my first talk, listen, and acknowledge. I know this is a really hard topic for you. Thank you for being brave enough for talking to me today. Acknowledge with your patient that sex can be really, really difficult. Now we're adding on cultures and religion, previous relationships, crappy first boyfriends, right? Like there's so many different layers to your patients. So my favorite, my sex education, Reality Bites. Again, there he is, Ethan Hawke. He's so smoky and greasy. But what did society tell you about sex? Anybody just want to shout something out? It should be easy. What's that? Penis and vagina, yes. Who's allowed to desire sex? Men. Who's supposed to be desirous? Women. What happens if you're not desirous? Oh, you ever see those memes of like, you realize the entire cosmetic industry would completely fall apart if women just decided that they were good enough, right? But like our whole society markets our ability to be desirous to somebody else, let alone ourselves. So is the best behind us? I kid you not, the best sex education in this country was in the 1990s. It's only gotten worse since then. Vulvar conditions, teaching in med school is the absolute worst thing that's not taught. So this is the big question. Everybody talks about, I want to want, and it bothers me that I don't. We've got FDA-approved medications for that now. It's fantastic. What about, I don't want to want, and I just don't care? Nobody talks about that. Those people get very dismissed. It's a big topic, many, many podcast episodes, but that exists in our world too. We've got to figure out how to handle this kindly and to say, it's okay. Let's learn about it. Why not? What do you think about it? I'm not here to make everybody have sex. I'm here to educate, help people advocate, and to realize this is an incredibly big, complicated topic, but you're all sex doctors now, and we can handle this. So in midlife, perimenopause, sandwich generation, not sleeping, caring for kids, hormones are changing, being dismissed at the doctor's office, it's very, very challenging, biopsychosocial. But we tell women, you can't use that because it's off-label. High blood pressure medication studied in men, we gave them to women. Cholesterol meds studied in men, we gave them to women. Sleep medication studied in men, we gave them to women. Testosterone studied in men. I'm like, that doesn't even make any sense. If you study everything else in men, give it to women. We should study things in women. Hormone fear culture, dismissal, the myth of natural. Oh, don't get me started. Everybody here is wearing shoes. Those aren't natural. I see some people who need help seeing. You have glasses on. Not natural. The myth of natural breaks down so fast, but we don't tell men, erectile dysfunction at 40, natural. Natural is often used as a way to control women. And then we tell them that they're cheating. Average life expectancy in the United States of America in 1900, 47. I will be turning the average age of death in America in 1900 in a month. But we're like, oh, Kelly, it's so unnatural to live longer. Modern medicine has allowed us to live to the average age of 81. We replace everything else at some point. I know when my daughters are growing up, they're not going to be like having philosophical conversations of if replacing the ovary is natural or not, but we do it with the pancreas, we do it with the thyroid, we do it with the brain. Anything we run out of, we replace. If you can't hear, I give you a hearing aid. It's not natural. And then we shame women for wanting pleasure. Again, know the fishbowl that you're swimming in. It's a heavy topic, but help is available. And the biggest thing, you will not die talking about sex. And that's like, once you realize you're not going to die talking about sex, everybody wants to talk about sex because it is a fascinating topic. Heterosexual midlife women have made Heated Rivalry the second most streamed show in the entire world. It's crazy. That's what heterosexual midlife women did. We're very powerful. Don't let anybody tell you otherwise. 1/3 of people stream Heated Rivalry at least 3 times. It's fantastic. There was actually an article in The Economist about it. Very, very cool. So if you take a penis and you put it in a vagina, how long does it take to have an orgasm? That's fascinating research. Turns out the answer is, well, what country are you in right now? Does the penis know that it's in Lithuania? No, but we have psychosocial cultural norms, right? So overall median, 5.4 minutes. We call that intravaginal latency time. It's very scientific sounding, but it differs between countries. Well, how long, if a woman puts a penis in her vagina, how long does that take to have an orgasm? I like how the abbreviation for it is titter. The mean reported, it's time to orgasm. The mean reported titter, 13.14 minutes. Well, that's basic math. 5 minutes is less than 13 minutes. If we prioritize one person's orgasm, she doesn't have an orgasm, okay? And 17% of these women had never experienced an orgasm, going back to the orgasm gap. So, penile-vaginal intercourse, insufficient to reach orgasm. So, if we know that's not good enough, and then women come to my office and they're like, I just need to get the penis in the vagina. If I say, I know you've been to a restaurant that only serves chicken, and I say, what kind of pasta do you want? Like, I have no idea. I've been eating chicken my entire life. It's very hard to know what kind of pasta you want if you've only been eating chicken. So it's actually a very challenging question to ask a woman, what do you want? She's like, I don't know, I've just been eating chicken. Don't we all just eat chicken? You're like, oh my good Lord, there's pastries, right? Welcome to the world of coffee drinks. That's amazing, right? We got pasta. We've got frozen we got ice cream, right? We're like, I just thought there was chicken. So my point is, it's a very challenging question to ask a woman, what do you want? I would say it's unfair. In a world of chicken restaurants, she has no idea. But here's the flip of it. What do you not want with sex? That's an easier question to answer. Okay, I don't like being cold. Great, let's not have cold sex. Okay, I don't want to feel unsafe. I don't want to feel used. So we reverse hack, and a really amazing sex therapist told me, think of the top 3 feelings that you want to feel during sex. Create the world where you have the sex where you can feel those. Some people might say loved, comforted, desired. Some people might say adventurous, unknown, a little bit dangerous, safe but dangerous, right? It's going to be different for everybody. But the easier question is, how do you not want to feel? Then how do you want to feel? Instead of saying the chicken aisle is all I ever knew. So these are the better questions. Do we want sex? What's changed in midlife? Right? When women come to me with low desire, and I'm trying to figure out, is this desire? Is this arousal? Is this orgasm? First of all, pain. Right? I love taking problems away from women. They're like, I have pain and I have low desire. I'm like, congratulations, you only actually have one issue. Nobody can desire sex if it's painful. Right? I like to take away problems. I take away interstitial cystitis diagnoses all the time because it's usually GSM. It's so fun. So taking away things and just normalize, we don't desire things that are painful. And women are having a lot of painful sex, right? So always suss that one out. And then with low desire, a question I really like is, did it used to be good? Did you used to want it? Versus my whole life, it's just been crappy, right? If they're like, oh my gosh, great relationship, super supportive partner, loved sex, and now things are different, I'm thinking hormones now. Right? Because she knows what was down besides the chicken aisle, right? And that's changed. So those are just the tips and tricks that I use to try to figure this out because it's a big topic. And sometimes just having those key questions can kind of streamline your life. I hate use it or lose it. Use it or lose it is not an FDA-approved sentence. Please don't use it. We don't like that. Super, super cringy. So you see it all the time on the internet. So I actually went back and dug. And I'm like, where's the sources cited for this? Where is it? I did this big search for it. I found the paper. 1983. My librarian at my hospital had to go photocopy a book that has, you remember old school? The journals go in a book, right? 1983. Vaginal atrophy in the postmenopausal woman, the importance of sexual activity and hormones. That kind of sounds like use it or lose it. This is a correlation study. Women with atrophy had less sex than women without atrophy. No kidding. They did not look at having sex and atrophy cured it, having sex, they didn't, this is a correlation study. 1983, this is where the use it or lose it came from. And if you see it cited, they'll cite this paper, which means they didn't read the paper. But this has reared its ugly head again. There was a study that came out of Japan literally just a year ago. And the media said, use it or lose it. Read the study, it's a correlation study, exact same thing. They repeated 1983 back. Women who have atrophy have less sex. That does not mean sex prevents atrophy. Caveat, vibrators, because of blood flow, this is the new data. So I get super cringy on use it or lose it, and then I say, but vibrators. So taking a penis and putting it in a vagina does not change your hormones, but blood flow does seem to make a difference. So that's the new exciting data, and using vibrators, calling them sexual aids, sexual health tools, if we don't like the words vibrators. I know this is a menopausal midlife, but postpartum sex. Nowhere is it ever researched that 6 weeks is the time to start having sex again after a baby. That is made up. It's totally made up. And if you actually do the research, women have lower levels of sexual desire at 3, 6, and 12 months postpartum. They've got hormone changes, genital urinary syndrome of lactation, right? And they're not sleeping. They've got new caregiving duties. Maybe they're back at work. This is a really important discussion on what does sex mean to you, right? Because here's the partner being like, our sex life was amazing, then this baby came in, right? But they might be feeling unloved. The last man on the totem pole, right? What does sex mean to you? What can we do besides putting something hard in an atrophic vagina to help you have those feelings? So this is not talked about enough. I just had to put in a slide. Again, sex is relational medicine. Many people love having sex with themselves. Many people like having sex with a partner, apostrophe S, right? So relational medicine, who's taking care? I'm a urologist, so I am very comfortable with testosterone and Viagra. And I used to not ask the men when they came in what their partner was. And then I became a better menopause doctor and women's sexual health doctor. And now I'm like, what's the plan with this? Where do you want to put it? And they'll say, oh, I'm married. And I'm like, I assume nothing, right? Where are you going to put this? And they're, oh, my wife, blah, blah. And I'm like, have you told her you're here today? No. And I'm like, I'm going to give you Viagra and testosterone, and your hope is to put this in a vagina? Who's taking care of her? Is she seeing somebody? Is she my patient? Should I know this, right? So asking your partners, if their goal is to have sex with somebody else, is somebody else being taken care of? Desire discrepancy is not a sex problem. What? This is a conversational, relational problem. I love my sex therapist. Where's my sex therapist? Right there in the middle. We love sex therapists. We want to be sex therapists. Once you can talk about sex and realize you're not going to die, you can talk about different desires in relationships and realize this is not actually about sex. It's about what we get out of sex, how we communicate about sex. What's the sex? Well, a real man needs to have sex every 48 hours. Oh, really? Where's that written? Right? So just talking about it uncovers so much. And I like to break the internet